So I'm Keri Thomas. I was GP for 23 years, worked in palliative care, hospice, and also worked at this interface between primary care and hospice and palliative care for a number of years, and now Professor of End-of-Life Care at the University of Birmingham and RCGP, Royal College of GPs, they call it Clinical Champion End-of-Life Care. So my main focus really is on training and developing training modules for generalists in end-of-life care. So that's the first. So next. I'm following it with you, Joe, if that's all right.
Yep.
So all around the world, a lot of us are facing the same kind of demographic time bomb, how we're going to be able to care well for all people nearing the end of life. For us, next year, after the Olympics, or around about the Olympics, there's a 17% predicted rise in number of deaths, which means that a tail end of lots more people. So it's the same everywhere, isn't it? So that's the big challenge for us all, and it's a new challenge. It's quite helpful for us to realise it's not something that we've ever faced before, caring for so many people nearing the end of life in the way that we have. And a lot of us all around the world are facing this whole dilemma and trying to deliver the best care that we can. And also we have a big issue. I don't know how much you have a big issue about cost effectiveness. We've got massive cuts in the NHS, and particularly related to inappropriate hospital admission. So we've got a big drive everywhere. All the policy documents are saying reducing hospitalisation and increasing care at home to save costs as well. So next one, end-of-life care in numbers. Is that all right? Are we there, Joe?
Yep, we're good.
Yep. So in the UK, roughly, our rule of thumb is 1% of the population dies each year, which is quite a helpful rule of thumb because it helps us work out what number of people in a practice or in an area die. And I don't suppose it's too different in New Zealand. I don't know what your figure is, but it's probably somewhere near that. It probably varies a bit, Simon, but it's quite a good rule of thumb anyway. And then we've got the increase in death. We've got most people not dying where they choose. About a third of people die at home, split between home and what we call care home, but you call aged care facility, ACF. Most, two studies have shown that 40%, in some areas 50% of people who've died in hospital, their deaths could have occurred elsewhere. So that was done by the National Audit Office, which is very extensive cost-effectiveness monitoring, which I think I've pointed Simon to a lot of their work. And they showed 40% of all deaths in general could have occurred elsewhere, and 50% of people coming in from care homes, residents of care homes. We know most people die of non-cancer conditions. Most people are elderly. The number of old is growing all the time, and just because something is available on ICU or whatever doesn't mean to say it's people's preference. So we're facing a new era now, as Simon and I were at the ACPEL conference. Really interesting to see how ICU consultants are also facing this dilemma. The National Audit Office also have done lots of costings and how much per day a hospital admission costs, but roughly they're saying it costs about £19,000 for a non-cancer patient. That's £19,000 for a non-cancer patient in the final year of life, and about £14,000 for a cancer patient. But we know that a varying proportion, but somewhere above 50% or so, of a person's whole lifetime costs are in the final years of life. So this is a very costly time as well. I'll move on to the next one. So that thing about the matter of life and death. So one of the things we try to look at is this 1% rule, that if someone was sitting in front of you who was in one of that 1%, who you thought was in the final year of life, what would you be doing for them? You'd be helping them to live as well as possible until the end. So it's a helpful way of looking at it, working from sort of death backwards, as it were, than sort of what we can provide forward. So when you start looking at population-based ways of thinking, you're trying to be very inclusive and trying to make sure that everyone is enabled to have good care, the dementia patient in their care home, and renal failure and heart failure and everyone. Whereas really a lot of our good, excellent work so far has been focused on cancer patients, as it has all around the world. So lots of hospices and palliative care services are branching out and doing more with non-cancer, but still the majority of people need other care provided by generalists. Next slide. Oh, right, sorry. Joe, are you all right to press these?
Yep.
So the NHS End-of-Life Care Programme, is that all right?
Policy development.
Oh, well done. So 2005, well, there was lots of work beforehand. We had Cancer Services Collaborative and something called NICE, but in 2005 they launched an end-of-life care program and specifically generically on end-of-life care and recommended these 3 tools, gold standards framework for care in the final year of life, mainly for community then. Liverpool Care Pathway, which I know you know really well, care in the final days, hours and days of life, and at that time was particularly hospital-focused, but has become more widespread, of course, and advanced care planning using various tools. We had one called PPC. So those were the 3, what they still call the end-of-life care tools, which sort of set a whole lot of things off. So then in 2008 was the Department of Health End-of-Life Care Strategy, which has had a big effect on us because it's mainstreamed end-of-life care thinking into the NHS as much as is possible. I mean, it varies still, but it's much more mainstream thinking now. And people are understanding that actually it's cost-effective care to look after people nearing the end of life as well. And then, yes, I put in a couple of things like National Audit Office and this thing called QUIP, which is about productivity. So we're really into cost-effectiveness here. I think it's probably an issue all around the world, but with budgets being really tight in this country, that's what we're looking at now. So the next slide is just a brief overview of the Department of Health End-of-Life Care Strategy. There's lots more to catch up on, but basically broken down into 6 steps and looking at from initiation of discussion and identification of people nearing the end of life all the way through assessment, coordination, delivery of care in the final days and care after death, and then carers, information, spiritual care going all the way through. So it's broken down into 6 steps, and but then GSF is sort of in and amongst most of those. LCP you can see in step 5, and advanced care planning obviously early on as well. So next one. Definition of end-of-life care. One of the reasons we all trip up over this all the time, and just to say, I've got a different slide as well trying to say that it's not about terminal care of the dying. It isn't just that. It's obviously taking it further back, and the General Medical Council in England and also this group called NICE, National Institute for Clinical Excellence, have adopted this definition, which is approaching people who are approaching the end of life when they're likely to die within the next 12 months. So it's roughly the last year, although that's a very broad area. So it includes people whose death is imminent, expected within a few hours a day. So it is dying patients in the final hours and days, but also those with advanced progressive incurable illness, general frailty, existing conditions that they're at risk from dying suddenly, or life-threatening acute conditions. So it's quite helpful, and most of us are thinking along these lines. Pragmatically speaking, it's roughly the final year, but we're definitely not just talking about dying, the final days. And I just mention it because we always trip up over that and use the term end-of-life care sometimes to mean dying. But in this area, it's about caring for people with life-limiting illness as they're nearing the end of life. So next one. Oh yes, RCGP and RCN patient charter. I just wanted to mention about that we've recently. So this is the Royal College of GPs and the Royal College of Nursing in England have just recently launched this patient charter, setting out from the patient's viewpoint about what they would like to expect. And I used this in the Advanced Care Planning Conference because 4 out of the 7 statements are about listening and respect. So there's a developing sort of people power here, and quite rightly, it's probably going to be patient groups and service users who are probably going to become more and more vociferous. So we hope with this charter will leave us some improved delivery of care. It isn't something that people feel that they can leave to chance anymore. So next slide. Yes. So the next slide. Is that all right, Joe? Are we doing okay so far?
Doing fine, Keri.
Well done. You're doing very well, because I do whisk through the slides. Sorry about this. Joanne Lynn was first to describe these different ways of dying, even though people come and go about how much they like them. But it's quite helpful because it helps us understand the way we've tended to think. And most people know about these. I'm sure your group know about these. The sort of more rapid, maybe traditional cancer patients with relatively predictable decline. And then the organ failure patients who might die at any stage, and it's very, very hard to predict which dip is going to lead to their death. And then thirdly, the very slow increased comorbidity group, elderly, dementia, frailty. And this, of course, is a majority. So although we broke it up into 5, 6, 7, so that is a GP's caseload of roughly 2,000 patients with 20 deaths per year. In fact, it's much greater, that 7. It's actually more like half, really. Single organ failure is decreasing, and cancer people are living longer with. So the great boom area are the elderly, the old with frailty, and the great boom years are the over 80s, over 90s, 100s. And then, of course, there's sudden death as well. But it's quite helpful to look at that to understand why we're struggling with some of these things, and why one model that might have fitted maybe the more traditionally cancer way of looking at it doesn't always fit, say, the organ failure or the patient with dementia. And we've got to use a jigsaw of different models to make sure that we deliver the right kind of care for the right patients, particularly for the elderly. So, next slide. Oh, yeah, so if you just press it a few times, Joe. So the tip of the iceberg, we find overall that in terms of quality outcomes, most people aren't dying where they choose, and many people still die poorly, and particularly the elderly are often omitted from some of these interventions and good care. And productivity, this is something we're focusing on in terms of cost. We're overspending on hospitals and unwanted treatment, and even if we just did nothing at all, it's estimated there'd be a 30% rise in cost because of demographic changes. So we need to think ahead, and proactive planning, advanced care planning, reduce hospital admissions, and we would say improve generalist workforce. But then that, if you just press that, doing nothing is not an option. So that was one of the things that changed within our NHS a few years ago, that now most subdivisions of healthcare, like PCTs, have taken on board that doing nothing is not an option. It isn't just nice people who do palliative care, it's all of us that are involved. And for economic reasons as well, it makes a difference. So it helped to argue with people who commission these services. So the next slide is just looking at the patient level, which could be sort of your father, my father, or us, any of us. So at the moment, maybe an older person in a care home with COPD and deteriorating, and no planning, and ad hoc visits, and all very random just because he's old and what do you expect. And people gradually struggling to cope, no advanced care planning, no life closure, and then suddenly one other crisis happens and we dial the ambulance, and he might die in the ambulance, might die at A&E, he might die on the ward, and often sort of betubed and pajamaed and not in the normal place. And then people not given much support and a feeling of being let down, and what do you expect? He's 82 and this is normal, but it's not, it's just not good enough. And really, in our country, this is happening on every hospital, in every hospital, almost every night of the week. So it's still happening too often that the kind of tragedies of especially older people being admitted to hospital when we could have done something beforehand is still happening. And although there are lots of things, moral and ethical dilemmas, I certainly feel, and many of us feel, that this is one of the moral dilemmas at the moment, that for lack of planning, too many crises are happening, and now there's a big drive to reduce hospital admissions as well. So, if you've pressed those red things, so at the moment it's still felt that there's an unacceptably poor level of care, especially for the elderly. And there have been 2 reports just in the last few months, and the third one a bit ago in England, saying how terrible care can be for the elderly. What we call the health ombudsman and the regulator have both been producing reports saying, especially in hospital care, can be really bad.